name is Joji Suzuki. I'm an addiction psychiatrist at Brigham Women's Hospital. And I'm here to talk about GLP-1s. And so, rightly or wrongly, this is one of the hot items today in addiction treatment research. So let's just jump right in. I do conduct NIH-funded clinical trials, one of them for GLP-1s. I currently do obtain some funding from Braeburn, previously from Indivior, but not at this point. I will be talking about the off-label potential use of semaglutide and tirzepatide, but this is an evolving issue. So we'll be talking about the pharmacology of GLP-1s, the evidence based around their use for treating substance use disorders, and yeah, what we all think about that. So speak louder. All right. Okay. Is there a way to increase the volume here? How is that? Is that better? Okay. So everybody here knows we're still in the midst of an opioid crisis. We're doing a better job today than we were in the past, but we still have a long way to go. And as a longtime clinician in this field, one of the sort of frustrations that really drove me to research is really this idea that despite having really good tools at our disposal, and we heard earlier about the challenges around, we should have more options and a menu of options for our patients. Buprenorphine, I'm a big champion of buprenorphine been for a long time. Clear, robust empirical support in improving outcomes. But the reality is long-term treatment retention is pretty suboptimal. We know that about half the patients will leave treatment within 6 months, 75% after a year. And when patients are not responding adequately to buprenorphine, we actually don't have any. After 20 years of prescribing this, we don't have any evidence-based adjunct to offer, other than potentially more buprenorphine or sort of the standard option that we provide to our patients, or transition to methadone. Again, those are all great options, but it feels like at this point we should have more. And a couple of years ago, Dr. Volkov, who's the current director of the National Institute of Drug Abuse, recommended sort of research priorities going forward, and specifically identified existing medications that are already FDA approved to try to test them for their potential therapeutic benefit for our patients, and specifically calling out GLP-1s as potential options. In addition to opiates, obviously alcohol remains a major public health problem. We know this. So NIAAA, which is the sort of the alcohol equivalent institute at the NIH, also is identifying the identification of novel therapies as a strategic priority. So GLP-1s. This is it feels like it's been a few years where you hear about some new headline about GLP-1s in the news. It was voted the breakthrough therapy by the journal Science in 2023 as a breakthrough medication of the year. And so what is GLP-1s? And I'm sure you've all heard a lot about this already, so I won't spend too much time here. But it was one of the first discovered incretins. Incretins are hormones that are released by the gut in response to oral intake of food. And so what you see on the right is actually the insulin release. It turns out if you inject glucose, you don't get insulin release. You only get that when you consume glucose. And that increase in insulin in response to food intake was, there had to be some signal that indicated food intake, and that was called the incretin effect. And the first one discovered is actually the glucose-dependent insulinotropic polypeptide, or GIP. And the second one was glucose-like peptide 1. So structurally looked like glucagon, glucagon-like peptide 1. And so GLP-1 was the second one discovered. So what did they do? So again, in response to food intake, GLP-1 is released. A big effect, of course, is the insulin release. So effect on the pancreas, leading to increased insulin release and the suppression of glucagon. There's direct effects on the gut itself, decreasing gastric emptying and motility. It has really wide-ranging effects. So I'm just really selecting a few. Again, I'm sure you've all heard so much of this already. But really what we're focused on here is the effect on the brain. And GLP-1, whether it's coming from the gut or somewhere else, it has a profound effect on food intake and satiety. And clearly this is a feedback mechanism. So in response to food, there's some negative feedback loop that gets engaged, and there's a direct effect on the brain system to reduce food intake. Now it's become clear now that it's actually probably not the circulating GLP-1s that are ending up in the brain, but probably some of them do. But now we have a bit of understanding that it's likely the GLP-1s that are produced and released in the brain itself. GIP also is released in response to food intake. Some overlapping effects, not exactly the same, but nevertheless still leads to release of insulin, and also leads to effects on the brain where there's food intake is decreased. So GLP-1 initially was discovered 50 years ago, 50 years or more years ago. But it was never really became a target of drug development because it actually gets cleaved by an enzyme and the half-life is extremely short. So within a few minutes, the native GLP-1 gets degraded. And that's part of the reason why it's probably not circulating GLP-1 is probably not doing a huge amount of work in the brain itself. But that really changed with the discovery of GLP-like hormone in this Gila monster. It was sort of by accident that this endocrinologist discovered it. But the reason for the discovery being sort of important is that exentin 4, which is the name of this peptide hormone, had a pretty strong homology to the human GLP-1. And when given to humans, actually had a much, much longer half-life. It resisted degradation by the enzyme DPP4 and had 100 times longer half-life. So suddenly it became clear, although it took 20 years from that time to actually lead to the first release of the FDA-approved GLP-1, but it became clear that there was a sort of a drug development pathway. If you tweak the structure of this peptide, somehow you can actually make it a more viable treatment option. And so that's exactly what happened. What you see up top is sort of the GLP-1 in the humans. And basically, sequentially, people came up with different structures to try to modify to resist the degradation by the enzyme DPP4. And so it's actually the peptide sequence at the very beginning, as well as adding different moieties to resist degradation or make it more potent at the GLP-1 receptor in various parts of the body. It turns out if you try to actually, one of the actually first strategies was to inhibit this enzyme itself. And so DPP4 inhibitors actually have been around for even longer, but they're actually not that particularly effective. And so that became a sort of a dead end. Okay. So again, GLP-1s were discovered very early on. And then the first GLP-1 that actually hit the market is exenatide. So structurally related to exentin itself. And that's already 2005. And so 20 years ago. And so that's one of the, I think, interesting history behind this medication class is that it's been around for 2 decades already, which is pretty fascinating. Then the second one was the liraglutide, then dulaglutide. By the time it hit dulaglutide, this is when it became a weekly injection. So both exenatide and liraglutide still has a very low, short half-life, required daily injections or multiple injections per day. Dulaglutide was the first one that became available as a weekly injection. But the efficacy remained somewhat limited. And so that really changed with the introduction of semaglutide about a decade ago. And then now we know that there's both injectable semaglutide as well as oral formulation of semaglutide. And then finally, the dual agonist tirzepatide. And I'm sure people may have heard that both tirzepatide is available as a weekly injection, but also a oral tablet. So at this point, we have 2 versions of the oral tablet, but most of the ones that are highly efficacious are weekly injections. So up until the introduction of tirzepatide, all of these medications are considered single agonist, meaning they're targeting the GLP-1 receptors. And single agonists, so semaglutide and all the ones that came before. But since that time, things have really changed dramatically. So tirzepatide is the first one that's considered dual agonist, targeting both the GLP-1 and the GIP receptors. And now there's emerging all kinds of different combinations. And one of the exciting ones, or at least people think, is a triple agonist, retatrutide, and which is targeting the glucagon receptors, but actually goes far beyond that in terms of targets. And this is just an example of how the drug development is happening. So what's really been interesting is this idea that GLP-1 receptors are expressed very widely in the brain itself, particularly in areas of the brain that are mediating reward-related behaviors. Now, it makes a lot of sense, obviously. Food intake is intimately connected to reward. It's a survival mechanism, and we need to eat, and these motivational sort of systems are really geared towards food intake in a very big way. So it's not surprising that GLP-1s are expressed very highly in the brain. And what's also really fascinating, at least from my perspective, I think from all of our perspectives as addiction specialists, the last time we had an FDA-approved, newly approved medication has been decades. Of course, we've had additional improvements to existing treatments like newer formulations of morphine, but the reality is we haven't had any new class of medications available to our patients in a very long time. With GLP-1s, I mean, in a very short period of time, really since the introduction of semaglutide and tirzepatide, which lead to dramatic weight losses. So we already know this, right? Many of these new compounds have undergone phase 2 trials already. So this year alone, you've had a whole bunch of new compounds already published with pretty dramatic results. The glipron class. So semaglutide, tirzepatide are peptide hormone peptides. So these are amino acid sequences that look like proteins. The glipron class is actually not a peptide anymore. It's actually a small molecule. And for that reason, it can be taken orally. So there's a whole series of glipron-like compounds that are currently available, not as efficacious, but that's a whole new class of non-peptide GLP-1 receptor agonists. Like I mentioned earlier, retatrutide is a triple agonist, currently probably leading to the greatest weight loss, 25% in 1 year. And that's the average. So half the patients lost more than that. And so clearly it's approaching the weight loss that you would achieve through bariatric surgery. And this is a weekly injection, which is pretty remarkable. And again, these are just a small sampling of these new compounds that are coming out. Survodutide, which is another whole different class. There's different combinations, so cagrilintide and semaglutide, or CagSem, is a combination, which leads to pretty dramatic weight loss as well. Maridapart cafraglutide is super interesting because it's actually an antibody, covalently bonded to GLP-1 receptor agonists. And the antibody itself has GIP. In this particular case, it's a GIP antagonist, not an agonist. For whatever reason, you can combine a GLP-1 agonist with a GIP agonist or an antagonist. And because it's an antibody, it's a monthly injection. So I think the phase 2 got published a few months ago with pretty dramatic weight loss results. And so we went from daily injection, weekly injection, and there's no question that we're headed towards monthly injection with different combinations and different receptor targets. So there's been a pretty robust amount of preclinical data really supporting the idea that GLP-1 receptor agonists lead to reduction in substance use in preclinical models. Personally, I don't put too much weight on preclinical models, but there's emerging population level epidemiologic data supporting this as well. And I'll just kind of go through a few of them. So let's see, this is a registry study from Sweden. And as we all know, in Scandinavia, they have these tremendous, national registries. You can follow a lot of people. And they looked at this 2006 to 2023 for those who were prescribed GLP-1s or not for indications around diabetes or obesity, and looked at alcohol-related hospitalizations in those individuals. And they also actually looked at the use of MAD medications. Basically, what they found is that there are lots of alcohol-related hospitalizations. Those on semaglutide or liraglutide had a significantly lower risk for alcohol-related hospitalizations. Interestingly, those on AUD medications, actually, they didn't see the effect. So I get at the population level, if there are prescribed medications, GLP-1 medications for diabetes or obesity, those individuals with alcohol use disorder had fewer alcohol-related complications. Again, observational studies, so it's hard to know causality. Here's another study like this. Again, there's a whole bunch of this. Is looking at the American population, 100 million individuals who are prescribed GLP-1s or other obesity or diabetes medications for type 2 diabetes or obesity, with or without alcohol use disorder. They looked at incidence and prevalence of AUD after receiving those medications. So newly emerging AUD diagnoses in the chart, or recurrence of the AUD and the persistence of that in the medical chart. And basically the bottom line is that what they found is that 50% reduction in both incident and prevalent AUD emerging in the chart for those prescribed specifically semaglutide versus other medications. And just one more, again, population sort of level of data. This is a target trial. What's the target trial? I think it was but it's a retrospective chart, again, review from American population. Oh, that's the same thing. Let me see. Sorry, here we go. This is the target trial. Target trial is going to take observational studies and sort of emulate or simulate a randomized trial. Don't ask me how that actually happens, but it's actually a cool sort of idea. But basically, those prescribe different medications for obesity or diabetes, and comparing semaglutide to them, and looking at opioid-related overdoses. And what this study demonstrated is that those prescribed semaglutide versus others had a lower incidence of an opioid-related overdose. Actually, dulaglutide did pretty good in this particular trial, but again, semaglutide doing better than the other medications. Again, these are all observation studies, so it's hard to know exactly what to make of them. So let's see, I'm going to try to sort of put this into context of how we understand addiction treatment. So substance use disorders, obviously, there are a lot of risk factors that contribute to it, including social determinants of health, early childhood adversities, home environment, poverty, et cetera, that interacts with genetics and that leads to propensity for initiation. And some individuals end up in this cycle, which you may have seen, this idea that people use, withdraw, start to want, and repeat. And sometimes I like to kind of divide this up into sort of different components when we think about, oh, when we think about substance use, obviously one of the biggest drivers is positive reinforcement. We like a particular substance, it makes us feel good, so we use it. And that, of course, is mediated through the reward network in the brain. But another thing that really happens is as you continue to flood the brain with something that's pleasurable, natural consequences sort of upregulate the stress system. And that becomes the sort of development of sometimes it's called the anti-reward system. And that actually ramps up the negative affect side of the brain, which becomes very apparent if you actually stop using. Withdrawal is sort of a good example of that. And in fact, as you increase the negative affect size, in fact, avoidance of that becomes another important driver of substance use. So withdrawal itself becomes, or removal of the withdrawal or removal of the negative affect becomes an important driver of use, which is negative reinforcement. Both of it is reinforcement. Either way, you like a particular outcome. Now, all this is happening in the context of incentive sensitization, where this development of this idea that this particular reward is important. That's one of the important functions of dopamine release in the brain. It's actually not mediating the liking. Dopamine release actually promotes the craving, the wanting. And as we all know, in addiction, the paradoxical situation that patients end up in is they don't necessarily like what's happening. Their lives are sort of falling apart, yet they can't stop wanting it, craving it, needing it, desiring it. And so it becomes trapped in this cycle of every time you want it, that itself becomes the negative reinforcement. The removal of the craving becomes highly reinforcing itself. And of course, this is happening in the context of difficulty regulating behavior itself, and also this interesting idea around the default mode network and sort of self-referential rumination that occurs. So putting that into context, and actually this is empirically well validated in terms of the increasing negative affect and cravings actually occur pretty reliably before a relapse event. And this is actually a study using EMA, or ecological momentary assessment, where people are kind of filling out in real time how they're feeling. And so before a relapse event, cravings are increasing, stress is increasing, negative mood is increasing, and after a relapse event, they tend to go down. So this is well empirically validated sort of model around substance use disorder treatment. So, and when our patients enter treatment, they actually have to understand two key things. Number one is that stressors can actually promote the development of cravings. Another thing is reminders or triggers or cues. And once you use, that alone itself can actually promote further use. And of course, cravings can never be eliminated entirely. And so part of recovery has to be that we have to understand how to regulate these parts. And AA, NA, counseling, therapy, peer support do a really terrific job of addressing many of these components. Our medications that we prescribe, like agonist therapies, actually do a great job of reducing cravings. Antagonists and agonists both actually help to block the positive reinforcement. And certain interventions like mindfulness, TMS therapy may also facilitate our patients to do a better job regulating their emotions and cravings. And so the big question is really, where in this sort of model does GLP-1s fit? And it's kind of fascinating to think about. So when we think about food intake, food intake goes through what's called a pleasure cycle. As you begin to get hungry, you start to want the food. And so in the modern era, this is like, I don't know, going to the fridge or ordering food or whatever it is, walking towards the fridge, and then you start to eat. And when you start to eat, you like it. So that tends to be reinforcing, but that promotes further eating. But at some point, it becomes aversive in nature. You feel full. So it actually aborts the intake, and then you enter the satiety phase. And we typically go through this multiple times a day, but reliably we go through the wanting, the liking, and the satiation part. What's super interesting is that it's not clear how this fits into the whole model of addiction, because we don't really talk about satiation in that way, the food. But what GLP-1s appear to do is really impact all three of these phases. So this is a quote. I don't think about tacos all the time anymore. I don't have cravings anymore at all. It's the weirdest thing. I love chocolate and thought I'd treat myself to a square, and it tastes like creamy nothingness. Even my favorite barbecue chicken does nothing for me now. It can be difficult for those who use food as a comfort. It has stripped away all dopamine away from the act of eating. And then my kids wanted to go to the pancake house after our swim today. A year ago, this kind of outing stressed me out a lot. I'd worry about eating too much. Now I just enjoy good food with my family. I'd have the sandwich I ordered without wanting the other half. And so these are pretty common, sentiments that you hear from people, and that's precisely why people lose weight. But it's really affecting the wanting, the liking, and this sense of sort of fullness. I've had enough. And it makes me really think about, in the earlier graphs showing that only some individuals go from initiation to addiction. And it makes me wonder, is it that for some individuals, they're able to use whatever particular substance and you've had enough and you can put it down. Naltrexone also does that for drinking. It helps us sort of reduce heavy drinking and potentially it's impacting our ability to sort of say we've had enough. But clearly, it's had a profound impact on food intake. Now, Oprah's been very open about her own experience with it. And her experience has been that, one of the things that I realized the very first time I took GLP-1 was that all these years I thought that thin people just had more willpower. They ate better foods. They were able to stick it longer. They never had a potato chip. And then I realized the first time I took a GLP-1 that they're not even thinking about it. They're only eating when they're hungry and they're stopping when they're full. And that makes sense. It quiets the food noise. And this has become the catchword for a lot of people. This sort of constant chatter about needing the food disappears. And interestingly, when I've spoken to people about this, this happens pretty quickly. And for alcohol, this seems to happen within the first few days. I mean, Johan Hari, and I have a slide about him also. Within the first day, the first morning after he took his initial dose, he noticed that the food noise was gone. And these are the starting doses where the doses are still not considered a full therapeutic doses. Here's some other examples. So how the GLP-1s may be affecting substance use, not just food. I remember going to dinner for the first time while taking Ozempic. I ordered beer, took a sip, and I couldn't finish it. You know how sometimes you taste a beer and it's like, oh my God, this tastes so good that I want to guzzle it. Well, I didn't feel like guzzling. I just really felt like sipping it. Another one here. Before Ozempic, I could consume a whole bottle of wine in an evening without trying real hard, along with a bag of chocolates. But when Ozempic, even one beer didn't feel good to me somehow. I had no idea this would happen. Nobody told me anything about the drug affecting alcohol too. This is another very common, report that patients have had. They didn't even know. They just noticed after the fact, and people are sort of spontaneously reporting this to their physicians that, I just kind of noticed that I'm not drinking much at all. And when I mentioned that we're doing research on GLP-1s, a lot of colleagues are very open to me about, about their GLP-1 journeys and a similar experience. They'll say, I don't really drink that much, but after starting GLP-1s, I don't feel like drinking at all. In fact, looking at a beer makes me nauseous. So there's something really fascinating happening. So is there any evidence base to really support that GLP-1s can attenuate substance use? So up until recently, there were a few. And I'm going to talk quite a bit more about this particular alcohol study, but there are 4 randomized trials that are completed, 2 for tobacco, 1 for alcohol. And for cocaine, it was a sort of a laboratory-based kind of evaluation, a single dose. So hard to know what that means, but basically 2 with exenatide, 1 for tobacco, 1 for alcohol, and 1 for dolichotide for tobacco. Interestingly, for tobacco, it's in combination with nicotine replacement or varenicline. The one that was in combination with varenicline was negative. It had no benefit compared to placebo. The one combined with nicotine replacement, actually those on exenatide did better. But the alcohol, it was a negative trial. So the very first randomized trial for alcohol actually was a negative trial. I'll try to go through this relatively quickly. It's a double-blind, placebo-controlled randomized trial. Exenatide 2 milligram injections versus placebo for 26 weeks. So it's a pretty robust duration, with a primary outcome looking at proportion of heavy drinking days. And also they did brain imaging as well. So here are the folks who were included. So, like 60 in each arm, so pretty robust, trial. And I always like to look at sort of the actual drinking history. So 17 days drinking, heavy drinking, defined as, 5 or more for men and 4 more for women in a given day. This is a European study, so they look at grams of alcohol consumed in a 30-day period, which means nothing to me. So that's about 5 to 6 drinks per day in this population. So they're not super heavy drinkers, but clearly drinking heavily. And here's the outcome. So no significant difference in heavy drinking days difference between the two groups. They both reduced their drinking. That's about 50% reduction in drinking over the course of the 26-week trial. So no difference. In fact, the placebo group had a greater reduction, unfortunately. And of course, but the good news is that it's actually working for the intended purpose. It's actually improving metabolic outcomes and hemoglobin A1C, BMI is lower. But obviously, when you compare exenatide to the newer class, remember, exenatide is the very first GLP-1 that was made available 20 years ago. So compared to that, clearly semaglutide and the newer versions are far more efficacious. In fact, in far less likely to cause side effects. But the point here is that this particular trial, no difference between exenatide and placebo. However, if you looked at if you stratified the population by their BMI, what they saw was that the blue line are those individuals who were obese, BMI about 30. There was a separation between the placebo group and exenatide, meaning the obese individuals had a greater likelihood of reducing their alcohol compared to placebo. But the opposite was true for those who were normal weight. So those who were normal weight actually had their drinking go up. So there was a worsening of their drinking over the course of the 26-week trial. So based on these results, actually many of the early trials for GLP-1s targeting substance use excluded those who were normal weight because there was a real concern that potentially one of the side effects of GLP-1s is that you may escalate your drinking if you're not overweight. And this is something you see with bariatric surgery. In the context of weight loss from bariatric surgery, there is a signal of increasing alcohol use and other substance use. But there, the difference is that with bariatric surgery, you're unable to consume food. Therefore, people may seek out reward from somewhere else. With GLP-1s, the idea here potentially is that, well, it's not that you're unable, you just don't want. But exenatide, less efficacious GLP-1 potentially may actually be harmful to individuals who are normal weight. The study also did MRI imaging and was able to demonstrate that there was a reduction in the brain response to cues related to alcohol. So there's a reduction in cue reactivity. And it's a sort of important biological marker that even if drinking wasn't affected dramatically overall, the brain's response to alcohol-related cues was decreased, suggesting that this may still be a very viable strategy. So for this particular trial, overall, no significant results, but those who were overweight actually had better outcomes. So finally, we had our first, semaglutide trial since that time that was published earlier this year. And it was a positive study. So that's the bottom line. But interesting design. It's a phase 2 double-blind, placebo-controlled randomized trial. It's a smaller study with a sort of a titration that is recommended by the semaglutide manufacturer, 0.25 for 4 weeks, 0.5 for 4 weeks, 1 milligram this was a 9-week trial, so 1 week at the 1 milligram. And that's a titration recommended by the manufacturer versus placebo for 9 weeks. But it was enrolling non-treatment seeking individuals. And so the reason for that, which may seem like an odd choice to do a clinical trial with a non-treatment seeker, is that the primary outcome for this group is to look at a self-administration paradigm. People have these, it's called the bar lab. Actually, you set up a bar in your lab, and you can actually have participants drink as much alcohol they want, and you can actually measure it sort of quantitatively how much they're consuming. So Christian Hendershot is a preclinical researcher. So interesting, like I've never designed a study like this, but they're science, PhD scientists, so this is how they approach it. But nevertheless, so again, the self-medication, because this is what they do for animals, self-administration paradigms in rodents. So the participants were presented with their preferred beverage and brand and could elect to delay drinking in exchange for money. So it's looking at sort of delay to drinking. And then after they start to drink, you can actually measure their blood alcohol level and how much alcohol they're consuming. So it's pretty interesting. And so the population they enrolled, so similar to the, in the prior study that I mentioned about, 17 to 20 heavy drinking, I'm sorry, so the drinking days were slightly lower. Where's the drinks per day? Heavy drinking days, okay. So that's about half of the previous population. So somewhat lower severity of drinking compared to the exenatide trial. And let's see, there we go. And here are the results. So looking at self-administration paradigms, so post-treatment after 9 weeks of semaglutide versus placebo, those who took placebo consumed more in that self-administration paradigm in the laboratory compared to semaglutide. There was a significant reduction. And this is a placebo group. This is a semaglutide group, and it's before and after. So both groups, you saw a reduction in how much they consumed. And this is actually the blood alcohol level during that test, but there was a greater reduction in those who received the semaglutide. However, overall, there was no change in heavy drinking days, at the end of the trial. But if you parse it out in terms of the different components of the study, the first half and the second half, there appeared to be a significant change in terms of drinks per drinking days in these components. And also towards the end, this is where the results does seem pretty interesting, is that the second half of the trial, those who got the semaglutide compared to placebo had a greater likelihood of not having any heavy drinking days at all. Not true at the beginning, no change in the placebo group. So the placebo group, they continued to have similar amounts of heavy drinking days, but those in the semaglutide had a much greater likelihood of having no heavy drinking days at all. And there was also a significant reduction in cravings. So it was sort of nice to kind of have that consistent finding that GLP-1s indeed appear to reduce cravings. So really the bottom line is that compared to placebo, semaglutide did reduce self-administration, no overall effects on heavy drinking days, but they're much more likely to have no heavy drinking at all at the end of the study. And there was a reduction overall in the drinks per day and alcohol cravings. So going back to this kind of model, sort of, it seems to, it does seem to maybe attenuate heavy drinking potentially. Like, does it interrupt your liking of it once you start to consume? So very similar to naltrexone in that way, that people consume, but you're able to put it down, which is the whole idea behind naltrexone. But it does also reduce the wanting itself. So the Q reactivity was reduced in the the Clausen trial. They didn't do that. I think they're going to publish that later for this group to look at whether the actual Q reactivity is reduced in this population, but certainly the cravings were reduced. But the self-administration paradigm also points to potential. Does it mean that it actually increases our ability to say, we've had enough? Is it somehow related to the liking? Again, this becomes confusing. Are they related? Are they the same thing? How does satiety fit into our understanding of the pathophysiology of addiction? It's not as clear. Okay, so let's see. This is a sampling. This is not the entirety of it, but this is most of it, of the currently planned clinical trials for GLP-1s targeting substances. And it's actually hard to find all of them because many of the companies that post these things actually don't use, there's no chemical name. So until you sort of look it up, you don't even know that it's a GLP-1. But we do know for sure right now that Novo Nordisk is already conducting a trial of individuals with alcohol-related liver disease and alcohol use using this, that I said earlier, the cagrilintide and semaglutide combination of medication. Already looking at this population. Eli Lilly, this is the only one they've posted so far, looking at mazdutide. That's another sort of new, they apparently don't want to use tirzepatide to test for alcohol for some business reasons, but they're testing a particular one called mazdutide. And there's actually 3 other trials with the GLP-1 that has no chemical name yet. It's, I forget the actual sort of, chemical number. They have 2 phase 2 trials targeting alcohol and 1 phase 2 trial targeting opioid use disorder. That's Eli Lilly. They haven't touched addiction space. I don't know if they've ever had. And so they're all in terms of many of these companies are already funding these trials that are globally being run. So this particular study, for example, I think I have like 40 different sites across the entire world, and they're doing it all at once because they have so much confidence that these things are going to actually work. And so there's a tremendous amount of interest in all kinds of substance use, but drug companies themselves are also really funding these studies. Now, interestingly, there's, so of course, alcohol, opioids, tobacco, these make sense. So it's nice to see that stimulant use disorder may actually have a potential therapeutic application. Binge eating obviously makes sense, but I'm surprised I can only find 1. I mean, you would think that there would be more, but, and one thing missing here is cannabis. Nobody seems to be looking at cannabis. So we have a fellow who's going to try to do a pilot. or other behavioral addictions, gambling, for example. So when you look up the news articles and anecdotal reports of so people are now talking about GLP-1s for all kinds of reward-related behaviors like gambling or too much shopping or whatever it is. But nevertheless, this has happened all very rapidly in the last couple of years. So it's really potentially exciting to see what would happen in the coming few more years. We're also getting into this, and we do have a randomized trial of semaglutide for those on MOUD treatment. We also have a tirzepatide trial for those who are completing inpatient withdrawal management, really targeting those with the most severe alcohol use disorder. And so if you do have somebody who's interested in doing a semaglutide trial for OUD, here's the QR code, and please pass it along to anybody who may be interested. We're happy to provide you with any recruitment materials for that. Now, interestingly, so maybe all that is the good news. And it feels like we're waiting for the other shoe to drop in terms of something horrible that's going to emerge from these medications. So Johann Hari, I'm sure you guys are familiar with him writing about addiction. He's very famous for that. He also wrote a book about GLP-1s, his own journey through this. And he lost a lot of weight. He's very happy with that. But he's also sort of voicing some concerns about some of the issues. So he kind of outlines, and he does a really nice job of talking about the 12 risks of Ozempic you should be aware. And of course, GI distress, pancreatitis, kidney issues, gallstones. So these are all potentially exclusions from many of the clinical trials. Vision changes. This seems to be real. When it was initially published, people were skeptical of it, but non-arteritic ischemic optic neuropathy, it's a sudden vision loss. So patients who have this will suddenly wake up with a blindness in one eye, which can be permanent. Now it's considered very rare, but now it's pretty convincing that it's actually a real complication. Thyroid malignancies can happen. Weight regain, obviously, if you stop GLP-1s, people reliably regain their weight, all of it. But the concern here is that on GLP-1s, people lose a lot of weight, and muscle loss, lean muscle loss is normal part of weight loss, whether it's GLP-1s or not. But there's a concern that people may sort of lose the weight without any effort, no additional exercise, lifestyle modifications, and the lean mass loss may even be greater. And when you stop these medications, you're in a potentially worse situation. Now you've regained all your weight. Now you have less muscle mass. A big one that's really emerging that's concerning is eating disorders, whether this is going to promote disordered eating or not. Suicide ideation, I think now it's much more, we're more convinced that it's probably not a real issue. This became a sort of a flashpoint for a period of time, but the emerging evidence base does suggest, if anything, reduction in suicide ideation, not increase. Overuse, of course, I think, and I'll say a little bit more in a second about the potential for overuse. I think it's true. And of course, we don't know the true long-term effects. Again, GLP-1s have been around for 20 years, but the newer versions with multiple receptor targets, the greater efficacy, they are still new. So we don't know for sure. So I think we do need to be careful. So you guys have all heard of a microdosing, right? Microdosing became popular in the psychedelic kind of context. Then it was microdose for buprenorphine. Now we call it, of course, low-dose inductions. But this is actually interesting. It has been around for a while. So in the early days of GLP-1s, especially after semaglutide came out, access was limited. So patients were asking their endocrinologists very early on, like, what do I do if I run out, if I can't afford it, if I can't get it approved? What should I do? So endocrinologists have been recommending a version of microdosing from years ago, recommending partial dosing, less frequent dosing, to make it last. Or once you attain weight loss, the question is, what do you do at that point? Do you stop? Do you lower doses? And so microdosing had become already something people are doing. New, however, made that into an actual approach. So it makes it more affordable. It's a lower cost point to enter. And when you obtain GLP-1s from these telehealth companies, it doesn't come in the proprietary pens. It comes in a vial that you actually draw up yourself. So what they figured out is that you can actually advise patients to take a partial dose. So instead of 0.25 milligram, which is the starting dose for semaglutide, they're starting now at a quarter of that, whatever that dose is, like 0.06 something. It's a starting point. And what's interesting is that now this is increasingly being recommended, not just for weight loss, but for preventing weight loss, or more as like a wellness product, reduction in inflammation, prevention of dementia, Alzheimer's. I mean, it's kind of scary to think about. And then now it's a big thing in the bodybuilding world to facilitate fat loss during the cutting. And now this is like a whole advertisement for retractor to purchase it to facilitate weight loss as part of your like wellness strategies. So this is like a whole new world out there right now of GLP-1s being a performance enhancing drug. And and also knockoffs. The FDA is already warning about the potential for knockoffs from many of these suppliers. If you actually go online to look for GLP-1s to purchase for these other suppliers, it looks pretty shady to me. Okay, now so and I didn't have a slide specific for eating disorder. We're definitely seeing a few more cases emerging of individuals who are on GLP-1s really beginning to manifest disordered eating in a very profound way. And if you have an eating disorder to start with, that really probably should be a contraindication for these medications. Most of the trials so far are not directly excluding eating disorders. But because of the growing concern, we actually, for our trials, we are. So if you have any history of eating disorder, binge eating, anorexia, bulimia, we actually don't feel that it's safe at this time. Okay, so should we be recommending GLP-1s to patients with SUD? So I think if they have the actual indications for which they are meant to be prescribed, of course, I think that should be fine. But I really think that we should be cautious about recommending these things until we've had better safety data, but of course, efficacy data. I think the anecdotal reports, both for the harms and the benefits, are both anecdotal. And I feel like we should pay attention to them, but until we have fully established efficacy, we should not be recommending them outright. And I think that the safety concerns are legitimate. I think once we start to prescribe these things for other indications or other reasons for other populations, we're not exactly sure what the safety is going to be. Disordered eating is particularly concerning. And reminder that we should be maximizing the use of existing therapies. Before we reach for GLP-1s, we should potentially be reaching out for existing therapies that are already approved and we know about their efficacy. Okay, so I spoke a little fast, but yeah. Okay. So we do need new treatments for our patients, obviously. So I think searching for new options, I think, is very legitimate and reasonable. And it does represent, and what's exciting, at least to me, is that it's potentially a new class of medications that we can offer with a completely different mechanism. And that's the norm in pretty much all branches of medicine. You don't just target one, but unfortunately for us, for pharmacotherapy, it's been sort of pretty limited to a very narrow range of mechanisms. The one study that's been published for AUD with the newer formulations, new version, semaglutide, again, there's only one. So despite all the hype, despite all the interest, there's been only one trial, promising results, but not treatment seeking, small study. So more to come. So there's a tremendous amount of interest in conducting these trials. But again, we should not be minimizing the potential for safety concerns. And I think that's it. Well, I left plenty of time for.
So Joji, that was the fastest I've ever heard him speak. And he left himself with plenty of time for questions. We really have 15 minutes, so nobody needs to get cut off.
Hi, I'm Phoebe Cushman from Spectrum Health Systems. Thank you. This was really fascinating and important work. I think I read some headlines somewhere that there is starting to be a distribution or creation of a generic GLP-1. And I guess, of course, that caught my eye because of, if any of these ever do become FDA approved for any substance use disorders, we're going to not, we're going to need Medicaid to pay for them.
Yeah, sorry I didn't mention, liraglutide is now generic. So currently it's the only one available generic. And I actually don't know what the cost is going to be. I don't know if anybody knows in terms of the actual cost.
It's very high.
Very still high, I'm sure, Yeah. But the assumption is the liraglutide will be the first weekly one that will likely become available generic next. But I'm not sure exactly when that's going to happen. But you're right. The access here is going to be very limited. So for the time being.
Thank you so much, Joji, Jessica Gray. Many questions, and I really appreciate you talking about the disordered eating and how to think about that in our patients. I take care of a lot of postpartum, pregnant postpartum people who have just a lot of trauma related to eating, body, et cetera, from their years of everything and use. And so I think it's just gonna be a really important thing to think about as we potentially learn more and expand indications for this if there's evidence. But I think my question is really around the duration of treatment, right? So is this going to be something potentially for addiction that someone takes for 12 weeks, for 12
Right.
years, right? Like any sense of what it looks like when people stop?
Yeah, the quick answer is I have no idea, just like so many anything else. But I think it's a similar kind of question that gets raised when somebody starts buprenorphine, right? Like how long and how often, and can I stop it at some point? I think the truth is that nobody wants to stay on these meds forever, obviously. But of course, the drug development pathway, I think they would prefer that. I think from our perspective, my own personal perspective is that, as we begin to have more options available, hopefully we're not just relying on one medication and that's it. The behavior change, lifestyle modification is such an important part. Like we recommend that regardless whether they're on buprenorphine, methadone, or any other treatments, the same should be true for, GLP-1s. So I don't know. I think, yeah, right now, what's clear is that if you stop these medications, you regain the weight. We don't have that data for substance use, but the assumption is that that likely would happen if you don't do anything else. If the only thing that changes is you take this med and then you stop, you probably will likely revert back to, pre-medication like cravings, etc. Now, the part that I'm curious is even with buprenorphine and methadone, over time, your brain actually does begin to recover in terms of not just your physical, psychosocial, functioning, but just like when you stop smoking, your body begins to heal, right? Like after a few days, you regain the sense of smell. After a few years, your risk for strokes, and other respiratory illnesses go down. And at some point, your risk for cancer is potentially as close to a non-smoker at some point, suggesting that the body is healing over time. It takes time to do that. So for addiction, there's at least a suggestion that your cue reactivity, it probably doesn't go away entirely in terms of this is now hardwired in your brain in terms of drug memories. But there's a likelihood that it actually goes down over time. And we know that from recovery, patients who recover, as you gain recovery time, you get better at it and you're less likely to relapse. So we know that becomes stronger and stronger. So the potentially, hopefully there's a way for us to gauge that and have a better confidence to say, you're probably safe to come off people, or you're safe to come off GLP. But then potentially we can come to a point where we can personalize these treatments and say, for you, maybe meetings is what you need. And for you, maybe medications, maybe microdosing GLP-1s, I don't know. So I really wish I could provide a better answer.
Hi, Casey Fisher. I'm a clinical pharmacist at Greater Lawrence Family Health Center. Thank you so much for this presentation. There's obviously being a clinical pharmacist, I do a lot with GLPs. And one of the areas that I don't get as frustrated with dealing with GLPs is in this particular space with patients that have, history of substance use disorder of any kind. Because I have seen, offhand cases of, where it really truly is life-changing for patients. My question, which you've kind of already addressed a little bit, is if at some point in the future, there's going to be, focus on these clinical trials that show, the difference between patients who are using the medications, with regards to their substance use and weight loss, but also compare that to patients who are in a more comprehensive program, and the differences between that. And then if they can come off of them.
Right. So I think that's a great question. So hopefully the trials that are coming down the line will incorporate that kind of an idea. So the other area that I do research is psychedelics. That's a big question there. Do you just give the drug, or do you combine it with psychotherapy or some other wraparound services? And so this, I think, applies here. Is it just a medication, or do you combine it with anything else? I mean, ultimately, I would believe that the combination is better, but the reality is not every patient would want it. So I think that becomes an interesting question, like, what are we obligated to do? What should patients do? Yeah, we heard earlier about we want options for our patients. What if a patient doesn't want to do these other things and change their behavior? Should we withhold treatment? For buprenorphine, we made it very clear, right? Refusal to engage in counseling should not be the reason to not provide it. So, but of course, the data suggested that you don't get a whole lot of benefit from it. But for GLP-1s, if you combine it with counseling, if it leads to better outcomes, do we make that a mandate or not? It's raised some interesting questions, but I agree with you. People should be testing the combination versus like monotherapy and whatnot. And just I didn't answer the question of eating disorder, but I think that needs to be incorporated in all the clinical trials in terms of safety monitoring. And I think patients need to be counseled about the possibility. Just like with bariatric surgery, weight loss can potentially lead to escalation of substance use. I think for GLP-1s, it may promote or facilitate disordered eating. We should be monitoring it and checking.
Yeah. Do you think that, like, with regards to funding, that would be something that would actually be looked at? Because I know, a lot of these drug companies, they're looking to just find new indications and promote these medications under different brand names. But for funding purposes, are they going to perhaps ignore the option of having those types of like trials?
I mean, so again, I think that's a great question. And again, when it comes to, let's say, buprenorphine, we have lots of patients who don't necessarily engage in other types of treatments, but we still offer the medication alone. And so I think it does raise some interesting and challenging questions that we're going to have to address. Like, what is the right thing to do for our patients? Again, I would believe that the combination is probably better if they're willing to accept it, but I don't know that we should withhold treatment if they choose not to.
Hi, Daniel Liao from MGH Primary Care Addiction. Great talk, Joji. Wondering if you could speak to any national dialogue around inclusion of structurally minoritized patients in these studies, just looking at the demographic breakdown of the Henderson's.
Yeah, no, absolutely. So that's just like so many other clinical trials, there's a real deficiency in both the researchers and the participants of not having a diversion of population. And so clearly a major problem, and we need to, change that, obviously.
Hi, Christine Ordway. I'm at Framingham Psychiatric Care. And I know a lot about GLP-1s. More than 10 years ago, I worked for 3 years in a diabetes clinic at the birth of GLP-1s. So I've been on dealing with them since they came out. And I am also a type 2 diabetic. I have been taking for 10 years a GLP-1, initially Trulicity, and then when I could no longer get it at the pharmacy, I switched to Ozempic. So I can attest to they're very effective, especially at keeping your hemoglobin A1C where it should be. But in my practice at Framingham Psychiatric, I cannot tell you how many patients I have had who are not diabetic, who have come in over the last year and a half, losing all kinds of weight on GLP-1s. And some of them were able to get it paid for by the insurance company, but the rest of them are all buying compounded, probably Ozempic, and doing great on it. And Eli Lilly has actually begun offering vials of Ozempic for about $300 because they were losing so much money to the compounding pharmacies. So I can also tell you, Wegovy's retail price is about $1,400 or $1,500 a month. Trulicity's about $1,200 a month. Ozempic, about $750 a month. And the big difference is Ozempic just comes in a long-acting insulin pen, whereas the others have those really nice little auto-inject pens that they're charging you hundreds of dollars for. I have observed in a couple of my patients who had binge eating disorders, one of whom 10 years ago had actually had bariatric surgery, was in my office in tears because she had been put on Ozempic or Wegovy, which is the same thing as Ozempic, very successfully. It controlled her appetite. She was back to her normal weight. She was doing great. Her employer switched to a new insurance company that would no longer cover Wegovy. And even though her PCP and I both wrote letters to the insurance company making the case that not only did she have a history that she needed it, but she'd been using it very effectively, they wouldn't give it to her. So she started buying a compounded version, and she's great now. She's happy. And kind of because of those patients, I mentioned to one of my daughters who has a history of binge eating and bulimia, I really laughed when I saw that Oprah quote in your program there. She was saying to me, oh yeah, she was doing great, but she just wished she could turn off the food noise in her brain. And I said, oh, well, maybe you ought to talk to your new doctor that she had an appointment with about trying one of these, because I'm seeing that it's effective in some of my patients. Well, of course, my daughter didn't wait to talk to her doctor. She bought some compounded GLP-1 and she said, Mom, it's incredible.
Well, glad it's worked for her. And yeah.
So I'm actually thinking eating disorders are not so much a risk, that this might be a very good thing for binge.
Good point. I felt, I should have just made a distinction between binge eating versus anorexia and bulimia. I think they're both within the realm of disordered eating. So for, at least for now, for safety reasons, we thought it'd be best to, exercise caution. But I think you're right. Binge eating disorder is pathophysiologically much more aligned with a substance use disorder as opposed to anorexia or bulimia. So I think those distinctions become important over time. But I think you're right. I think binge eating disorder may be a clear indication for something like GLP-1.
Okay, my last.
Yeah, just gonna happy to discuss, we can chat afterwards. Thank you.
Hi, I'm Matt Rogalski from a couple of Acadia CTCs, including Fall River. I just wanted to take a quick sec to thank you, because for the first time this week, I had a patient who I'm treating ask for an advocacy letter because her insurance declined her PCP from giving her a GLP-1 for her obesity. So I actually had to write an advocacy letter. So now I'm going to take what you've got here condensed very nicely and put a little bit more beef in there for the next time.
Okay, well, thank you for letting me know. Appreciate it. Thank you, everybody.